ABG always has an anion gap. The anion gap is sodium minus chloride plus bicarbonate. Normal anion gap is 8 to 12 milliequivalents per liter. Think of anion gap as unmeasured anions, lactates, ketones and toxins. First, when there is a metabolic acidosis, look at the pH and bicarbonate. pH would be decreased, bicarbonate would be decreased. This is metabolic acidosis. Next, calculate the anion gap. A high anion gap metabolic acidosis, otherwise known as HAGMA. Acids are added, bicarbonate is consumed and anion gap rises. The causes, the modern mnemonic is gold mark. G for glycols, ethylene glycol and propylene glycol, the antifreeze agents. O is oxaprolene, paracetamol toxicity. L is lactate, as in shock and sepsis. D is diabetic ketoacidosis, one of the most commonest cause. M is methanol poisoning. A, aspirin salicylate poisoning. R is renal failure. K is ketoacidosis, alcoholic and starvation ketoacidosis. Lactate is the most common in the ICU. Decay, anion gap rises much before the glucose falls. Toxins, always check osmolar gap. A normal anion gap metabolic acidosis, otherwise known as NAGMA. Here, bicarbonate is lost, but it is replaced by chloride, and the anion gap remains normal. Causes GI loss, as in diarrhea, renal tubular acidosis, iatrogenic, when large amounts of normal saline are pushed into the circulation. So these are the causes of normal anion gap metabolic acidosis. Hyperchloremic metabolic acidosis is NAGMA. That's what I told in heavy use of normal saline for resuscitation. Low anion gap is rare but not uncommon. Causes include hypoalemia, is the most common cause in ICU. Occasionally paraproteinemias like myeloma can produce. It may be a lab error, and very rarely lithium and bromides can produce low anion gap. The key correction should always correct anion gap in ICU patients by correcting it for the albumin. Always look for mixed disorders, because mixed disorders is the rule in critically ill patients. Use the delta ratio. Interpreting the delta ratio is that when delta ratio is 1 to 2, it is a pure HAGMA. When it is less than 1, it is a coexisting HAGMA plus NAGMA. High anion gap with a normal anion gap. When it is more than 2, it is HAGMA with a metabolic alkalosis. So, bedside clinical algorithm when you get a ABG is that confirm there is metabolic acidosis, calculate the anion gap. If there is an increased anion gap, think of gold mark, the mnemonic that we told. If it is a normal anion gap, it is either GI or renal. Correct for the albumin, check the delta ratio and always correlate with the clinical context, what the patient is having. So, normal anion gap does not exclude severe acidosis. Hypoalemia can mask a HAGMA. Mixed disorders are not common and is the rule. Large amount of saline infusion is the iatrogenic cause of acidosis. Decay plus vomiting, normal pH can be misleading. Anion gap tells you whether acid is added or bicarbonate is lost, and the delta tells you if the story is complete.